The show where we break down all the myths and talk to you about all the new information on infertility. I'm Dr. Rahi Victory, a fertility specialist, and welcome to our show. If it's your first time joining us, we usually review an article initially, and then we go on to answer questions live. So if you have live questions, hang around just a few minutes, and we will answer all your questions and go over them with you. And we have our wonderful Tarek, the mystery man of the show, off to the side, and he's working all the electronics. And he's going to see if he can squeeze in the slides. Can you, do you think, or is it going to be impossible? That's a big ask, right? Okay, so welcome back. We've done a number of shows recently where we were either interviewing folks or just went straight into questions. And a new article came up that I wanted to share with you guys because it is hugely important. So as many of you know, when you're doing infertility treatments, in particular IVF, one of the things that you need is progesterone. So whether you're doing a natural cycle or a stimulated cycle, there's always some amount of progesterone that's necessary. And there are loads and loads of studies that have supported the fact that you need at least some extra progesterone to achieve success. In particular, in cycles where there is suppression first, there may not be any natural progesterone, and therefore there has to be some that you add into the cycle in order to get a successful outcome. So one of the things that people have constantly gone back and forth on is whether or not doing injectable progesterone, which is pretty much like the standard in North America, or at least in the United States, is equivalent to doing the progesterone in vaginal suppositories. So there's kind of three routes of progesterone. You can do an injectable progesterone, you can do a vaginal progesterone, or you can do oral progesterone. So let's dispense with the easy part first, okay? Oral progesterone is by and large not a good option for people unless you have an inability or an allergy to the injectable or the vaginal, because bioavailability of ingested progesterone is poor, and there are actually studies that show lower success rates with the oral progesterones. The other two options, the vaginal and the injectable. So the injectable is always progesterone in some kind of oil. And then the vaginal, the main three, well, there's four. So there's crinone, there's prometrium, there's endometrium, and then there's the custom compounded suppositories. So this study said, let's take a look at three different regimens. Let's look at patients using daily injectable progesterone, patients looking at daily vaginal progesterone, and then a mix where they did vaginal progesterone every day, but then they added in injectable progesterone once every 3 days. There was a previous study done by Shady Grove Fertility, which is a big fertility company in the US, and they demonstrated that once every 3 days was equivalent to once every day. So this study kind of built on that and said, what about doing once every 3 days injectable, but we also add in the vaginal, and what kind of results do we get? So interesting study. It was done in the US and at Shady Grove, actually. So it's an extension of the study they had done before. And what they did was they took 1,346 candidates, 142 of whom decided to not enter into the study, and 22 decided to delay their embryo transfer cycle, and then 57 met exclusion criteria, and I'll go through the exclusion criteria because they're pretty strict. And then that left them with 1,125 patients. So what did they do? They ran a randomized controlled trial. Now, this is literally the hardest thing to do in all of infertility, because it's very hard to convince people to accept blindly going into a group that they may not want to be into. So if you say to anybody in the infertility world, I can give you injectable progesterone and vaginal progesterone, or I can give you just vaginal or just injectable, pretty much everybody's going to probably opt for two, just based on the fact that they think 2 is better than 1. And so this was a really difficult thing to do. And in general, in the infertility world, running any kind of randomized controlled trial is difficult to recruit patients for. So it's very impressive numbers that they actually ended up with 1,125 patients to randomize. So from that, 444 went into the injectable progesterone, 432 went into the vaginal and injectable, and 249 went into just the vaginal progesterone group. And then again, there were some exclusions for cycle cancellations and things. So they ended up with 421 in the injectable group only, 408 in the combined group, vaginal and injectable, and 231 in the group that did the vaginal only. So from that, there were about 20 people in each group that fell out afterwards because of various complications and factors. There was an error, they went through something with genetic screening or something like that. And so they had to exclude several people from that. So they actually had 2 levels of investigation. One was doing the intention to treat analysis, which is analyzing people based on what they were supposed to do, which is the correct way to do it. And then the other one was per protocol, which is here's what they actually did instead of what they were supposed to do. And a per protocol analysis is more real world, but it's actually not statistically valid compared to an intention to treat analysis. Okay, so let's take a look at who they included and who they didn't include, okay? So there were some very significant factors that they looked at in terms of who was involved and who wasn't involved. And the important thing was, so number one, they looked at various age women from 18 all the way up to 48. So quite a wide age range. I mean, most studies are going to be a little bit narrower. This really kind of included everyone. Why someone 18 is doing IVF is completely beyond me, but anyways, that's what they included. So the exclusion criteria were good. They were very solid. So didn't include anyone using a gestational carrier, no blastocysts that were created from frozen eggs. So these were all fresh egg cycles. So again, more applicability to folks out there who are trying on their own. No embryos that were frozen and thawed and refrozen and rethawed. None that were done by slow freeze instead of vitrification, which is the method we use and most civilized centers now do. None that were biopsied, so none that were going through pre-implantation genetic testing. And then none that were frozen at the non-blastocyst stage. No significant diseases, non-smokers, non-drug users, non-drinkers, reasonable body mass index, so they weren't less than 18 or over 38 within the last 3 months. And then some other clear ones like they weren't pregnant already and things like that. So it was a very robust design where they, really stuck to a good group that is very reflective of the population you want to be studying. Okay, so what did they find once they did the study? They basically have this amazing chart, and I don't know if we have it up, do we? Yeah, okay, perfect. So Tarek managed to get the chart up. Big round of applause for Tarek. I love this guy. So you should be able to see table 2. Okay, so in table 2, you can see positive HCG, biochemical loss, which means you had a chemical beta HCG level, but then it dwindled back down. Clinical pregnancy rate per transfer, which is seeing a fetal heartbeat. Clinical loss, which means a loss after you've seen a fetal heartbeat or a pregnancy. And then total pregnancy loss, which is obviously a combination of those two. And then the live birth rate. Okay, so we're going to stick with the side that's on my left. You're probably right. And that's the intention to treat analysis. So in that intention to treat analysis, the p-values are what show you significance. So if they're less than 0.05, which all of those ones are, all of those are significant. Okay, so you can see IMP was the injectable only, VP and IMP was vaginal progesterone and injectable progesterone, and then VP was vaginal only. So how many were positive per transfer? So just positive preg tests. 66% in the injectable only, 62% in the vaginal and injectable, and only 55% in the vaginal only. And when they sub-analyzed it between injectable and vaginal, it was still significant, but it was not totally significant when they compared vaginal to the once every 3 days and the vaginal together. So then they looked at the pregnancy loss rate, and this is really interesting data because I haven't seen this before. So 18% had a pregnancy loss in the injectable group, 13% in the vaginal and injectable, so that's lower, and 32% in the vaginal only. So you're getting almost double or triple the rate of miscarriage if you're on vaginal progesterone only. This is a big issue because we see patients coming to us all the time who say, especially from Europe, who say they're only on vaginal progesterone. It's not enough. And this study very much proves that, because you've got this very high significance factor demonstrating in the intention to treat analysis and on the other side in the per protocol analysis and between the groups, that the biochemical loss rate is going to be much higher, okay? Clinical pregnancy rate, same kind of pattern. So 54%, 54%, and then 37%. So huge numbers, again, showing that your pregnancy rate is much higher when you're on an injectable or injectable with vaginal versus vaginal. Clinical loss rate, 19% with injectable, 15% with both, 27% when they were on vaginal. So again, much, much higher numbers, almost double the loss of pregnancies when you're on vaginal progesterone versus the injectable with the vaginal. And then, of course, the holy grail live birth, 44% when you were on injectable, 46% for injectable and the vaginal, and then 27% when you were on the vaginal alone. And again, they demonstrated significance comparing the injectable to the vaginal, but they didn't see a difference comparing the injectable to the vaginal and the injectable together. So either of those two are fine, but injectable versus vaginal, it's much, much superior to do an injectable version. So the graphic part of this, do you have figure 2 as well as table 2? Yeah. So figure 2 shows it to you in a graph format. Again, you can skip the per protocol. The blue line shows you what your rates of live birth per embryo transfer were for doing the injectable progesterone. So that's the blue bar. The red one is the combo of the injectable once every 3 days with the vaginal. So that gave you your highest success rate. And then the daily vaginal alone, almost half the success rate, which you can see very clearly there graphically. So this is really, really important data. Now, the other element of this that they also study, which was super cool, is they analyzed to see how many of the patients got pregnant based on the progesterone concentrations. So the progesterone concentration is something that has also been studied before, but not everybody has always agreed on what that information means. And some people have said, well, you don't need to screen for the levels. Other people have said you do need to screen for the levels. So these guys showed that when your progesterone concentration, when they looked at their overall population, was higher than 9 nanograms per milliliter, which is roughly, I think, around 30 to 40 picomoles per liter, is they got the highest rate, which was 48% per embryo transfer live birth when the progesterone level was higher. When the progesterone level was less than 3 nanograms per mil, which is quite low, then they got a 12% success rate. So 12 versus 48. So a 4-fold increase in your live birth rate based on your progesterone levels. And then for the pregnancy rates in between, they did show that there was a difference. So between less than 3, it was a disaster. Between 3 to 9, it was a little bit higher, 37%. And then that 48% you achieve when you get above 9. So they did show that this was very, very important. And they also went back and then said, well, which group had the lowest percent of or lowest concentration of progesterone, and they showed, of course, that it was in the vaginal group. So people ask me all the time, why are you using two forms of progesterone? Well, the vaginal progesterone has a very good ability to get into your uterus, but the injectable progesterone is very good at getting into your bloodstream. And that's how you get that serum progesterone level up. And again, this study proves it because the injectable is going into your bloodstream. And you need both because the progesterone in your body normally comes from the corpus luteum, which is the leftover from your egg when you release your egg. So what happened in this study is that they're demonstrating that the progesterone level is not sufficient if you're just using a vaginal. And that makes sense because in your body, when you release the progesterone from the corpus luteum, some of it's going kind of right close to the uterus, so it's what we call paracrine. And some of it is going into your actual bloodstream, which is endocrine. So you need both. And to mimic that in real life, you need vaginal, but you also need the injectable. So people always ask which form of progesterone is best. There is no question that using both gives you at least as good a result as doing injectable alone. And the combination seems to have the lowest rate of miscarriage of any of the choices. So if you have the option of just injectable, just vaginal, or both injectable and vaginal, in order to maximize your success and minimize your miscarriage rate, you want to be on both. Now, should everybody be doing once every 3 days or every day? I'm still of the opinion that pregnancies like balance, and progesterone does not last 3 days. So that, up and down kind of pattern you're going to get is probably suboptimal in my opinion. And so I actually still recommend our patients do it every day plus the vaginal. And with that, we're getting incredibly high success rates. So is it a factor of fiction that there is a single type of progesterone that should be used or a single approach? There is. It's actually one approach that involves both approaches, and that is injectable and vaginal. Do not just do vaginal progesterone. Your miscarriage rates are 2 to 3 times higher. Your success rates are much, much lower, and your progesterone levels will not be high enough. So these are really, really important for people that are trying. And we have sometimes got patients that can't tolerate the injectable progesterone. That's a different situation. You got to make the best of it. But for anybody that can or has a choice in what they're doing, make sure you're on both. That's really huge. So thank you for joining us for the review portion of Fertility Fact or Fiction. We will be back again next week on Tuesday with another exciting topic, and we will present that to you soon. And in the meantime, we're going to start taking questions now. So I will grab my coffee, and I'm sure there's a lineup of questions as usual, right?
A lot of progesterone.
Oh, a lot of progesterone questions. Cool. All right.
Built up a base to it.
All right. Terrific. And thank you to all of our viewers on Instagram. We finally topped 10,000 and then rapidly 11,000. So we're kind of excited about that. Good news. And we are probably a few days away from hitting 3,000 on YouTube. So that's pretty cool too. So thank you. And I think we now have a TikTok channel too, don't we?
Yeah.
We're now on TikTok as well. So you can check us out there. I will not be twerking or dancing, sorry. All right, hit it.
Okay, we'll go with the first question. A lot of them came once you started going, but
okay,
as soon as 8 o'clock hits,
boom, boom, boom.
Yeah. So, do you need estrase for an FET? I'm wondering about negative effects on potential baby due to having to take it through the first 12 weeks.
Yeah. So, more and more studies have come out demonstrating that you should minimize the amount of estrogen you're using. So, we try to avoid all estrogen use. In our case, estradiol. So we try to minimize it, but if it's necessary, you can't get the lining to thicken enough with letrozole or with whatever stimulation approach you're using, or just natural, then we do give a little bit, and we really try and minimize the amount that we're giving. So we'll start with half or 1 tablet daily and then add as we go. It does very much depend on the patient too. So if you're 50-year-old using donor eggs, excuse me, and you've been menopausal for several years, you may need estrogen because we're not going to get a response from giving you letrozole. Whereas if you're a young woman and you have a good, strong response to the letrozole, you may not need anything. So it does depend on the patient, but we try to minimize exposure to estrogen because more and more they've demonstrated that A, it probably reduces your success rates, and B, it also very likely increases the risks of the pregnancy, including preeclampsia, IUGR, preterm labor, things like that. So great question.
What to do for a partial DQ alpha match and low LED levels?
So that's a great question. DQ alpha mismatch, no one is 100% sure about. The people in reproductive immunology do believe that it's a major issue, and there are studies that support that as well. That is something that's very difficult to overcome if you are a DQ alpha mismatch, because you can't correct the genetics. From an LED standpoint, you can use IVIG, or you can do lit therapy, where they can help expose you to your partner's blood to minimize your reactivity against their blood type, so that if the embryo, which is half your partner, enters your system, your immune system doesn't think it's completely foreign. So normally that kind of thing is done by reproductive immunologists. I work closely with one of my colleagues in Toronto, and he takes care of that kind of case for us. We haven't really started doing it here on site because it's quite involved, but we've had phenomenal results. Actually, we had one of those awesome group FaceTimes with our entire office with one of our patients recently who did some reproductive immunology treatment, and I got to shout out to her from the whole office that she was pregnant now. So super exciting for us. Congrats to you, you know who you are. And we're super pumped about that. It was really fun. So anyways, yeah, it does work. We're using a lot of subcutaneous immunoglobulin therapy. That seems to work really well for us as well. Intralipid steroids. We have kind of a whole immune protocol. So make sure you reach out, and we can connect you with the doc we work with in Toronto, and they can help you through us, and we'll get you the care you need.
I love questions that are questions of your other questions.
Oh, yeah, sure.
So does your embryo math video apply to those with PCOS? If not, could you please do it for someone with lean PCOS age 34? Also, does having PCOS always mean poor egg quality?
Okay, so I'll answer that backwards. So having PCOS does not always mean bad egg quality. PCOS is manageable even if it's lean. The embryo math does not, I mean, there's enough information in there for you to kind of build your own equation, but it doesn't apply to PCOS women, because PCOS women are going to make many more eggs typically. So if you're looking at one of those categories where, for example, the average was, let's say, 3 to 9, you're going to be way higher than the 3 to 9. So you need to factor in, and you can do the calculation. You got to watch the embryo math video, figure out what category you would be in. If you're PCO, you're always going to make a lot of eggs. So take one of the higher categories, use the percentage of genetically abnormal embryos you will have. So the fertilization rates, the blastulation rates, the genetically abnormal rates will all stay the same, but your egg number will be different. So you said you're 34, let's kind of move it towards 35 because that's one of our examples. So you know that in a good center, somewhere between 70 to 90% of your eggs will be fertilized. So let's just theoretically say you make 20, you probably end up with somewhere between 16 to 18 embryos fertilized. Anywhere from about half to 60% of them should turn into blastocysts, let's say half. So you're going to end up with 8 or 9 that are going to end up becoming blastocysts, and about half will be genetically normal. So you should have about 4 or 5, in which case you're going to end up with at least a 95.2% chance of having one birth, and very likely a high chance of having more than one birth. So you can use the embryo math video for yourself. You just got to kind of rejig the math a little bit, or reach out to me and I'll calculate it for you. Great question, and thanks for bringing it up. I loved making that video. It was a lot of fun, and it was a good video. So, yeah.
Hello, Dr. Victory. Are partners allowed to be present during retrieval at VRC yet?
No. So one of the things I'm fairly well known for is that, excuse me, we want our patients to be very, very pain-free during their procedures. And as part of that, we make sure that you are comfortable, and many of our patients fall asleep during the procedure. So having a partner there is actually more anxiety provoking than anything, because they're worried that their partner is not communicative or unable to communicate, and they're like nudging them and wanting to wake them up, and we don't want them awake. We want you comfortable so we can do what we need to do for you, and you have no recollection other than that, oh my God, that was so much better than the other place I went to. We get that all the time. I just had it yesterday. It's very frequent for us that patients will say to us, oh my God, that was a much better experience than I'd ever had anywhere else. So we want to keep you super comfortable. And in order to keep you super comfortable, we don't have partners in there with you. Transfer, no problem, but not during the retrieval.
Do you ever recommend IVIG for elevated natural killer cells, or are intralipids as effective?
There aren't head-to-head comparisons of intralipids versus IVIG. So yes, we do recommend subcutaneous IG therapy for elevated natural killer cells, in addition to steroids and other treatments. I was up all night, so my voice is going. I'm sorry, guys. So the one thing you need to understand, at least in Canada, is that IVIG therapy is incredibly expensive. The last patient I did it for, who insisted on it, it was $5,400. And that wasn't with us charging her anything, because I felt so bad. It was just so expensive. We actually didn't charge her anything. So that stuff is astronomical to do. And so we use subcutaneous IG, which is actually free, and we're still getting very, very good results with. Yeah, but we do recommend it. One of the two. You can also use intralipids. Steroids will be helpful potentially as well. Heparin may be beneficial because it's a good anti-inflammatory.
Had a recent loss at 7 weeks, natural conception. Partner had borderline sperm, and scan showed varicocele.
Okay.
One of those words. He is taking Fertile Pro and Maca.
Yeah.
What should we do with varicocele? Urologist appointment is in November.
So there are good studies that show that sperm will improve at least transiently, meaning for a short time after a varicocelectomy, especially if it's large. Your partner can probably improve the sperm in the meantime by doing all the things we always talk about. So number one, ejaculate every 2 days. Number two, loads of vitamins. Number three, keep your testicles cool and loose. So don't wear briefs, wear boxers, and don't wear anything tight. Let your pants be loose, sleep naked, that kind of thing. And sleeping naked helps with ejaculating every 2 days, hopefully. In terms of vitamins, you need loads and loads of fertility vitamins. Fertile Pro is a great product. Stay out of hot tub saunas, jacuzzis. Keep your cell phone and laptop away from your lap. And then most important of all, no smoking, no drinking, no drug use. And when I say none, I mean zero. For guys that also have high sperm DNA fragmentation, we now have gone to doing a second sample 3 hours after the first, and that helps a lot as well. It drops the DNA fragmentation quite a bit.
I've recently read about TRT and low-dose HCG to preserve fertility. What are your thoughts on this? My husband takes HCG for low testosterone and feels awful. Letrozole made it worse. Thoughts?
Well, there are a lot of people that use HCG while they're on testosterone replacement therapy to offset the negative fertility impact of testosterone. If you're on a low dose and you monitor your testicular function, meaning sperm production, you may get away with it. There aren't very many studies on this, so we don't know for sure if that's safe or not. It actually comes mostly out of the bodybuilding culture, where this became a thing and people started doing it to protect their testicles. But I can tell you, as a physician that has actually quite a number of well-known bodybuilders who are patients, it doesn't actually work that well. They still have terrible sperm if they're using a lot of steroids. So a lot of testosterone steroids or anabolic steroids. So you do need to be cautious. If you do it with monitoring, it'll be reversible because you can always stop early on. But for guys that have been taking testosterone for a long time, it can do some permanent damage and very much suppress your testicular function even permanently. So I wouldn't overdo it, and I would monitor it if you are going to try it. It is worth trying. Ultimately, there's always that balance between, what's tolerable and what's not tolerable for your partner. So one of the things you could do is come off for a reasonable period of time off of everything, or at least stay on just the HCG. Make some sperm samples, freeze them, and then go back to doing whatever you want. Now you're protected for your future. And that's something we've done even in the trans community, where if we have someone that's transitioning, we just get their sperm and then they can go on whatever hormones they need to.
For dual trigger, would you ever increase the dose of HCG? Would that increase the risk of premature ovulation?
No, it increases the risk of OHSS. So there was a study published in Fertility and Sterility that we reviewed, I think about 2 years ago, which showed that if you are doing frozen embryo transfers, you need a little bit of HCG in addition to the GnRH trigger, even with a frozen embryo transfer, to get the best quality embryos and get the highest success rates. So we do use a little bit of HCG with our GnRH agonist trigger to get that dual trigger effect. There aren't too many people that need a higher dose of HCG. I'll give you a good example. I had a patient very recently, just on the weekend, we did a retrieval on, who had very, very low LH levels. When you have a very suppressed LH level, there is a reasonable chance that the GnRH agonist by itself will not work. So we had to give her some HCG, but she did have a very high estradiol level because she had made a ton of eggs. So we only gave her 500 units of HCG. The LH, we monitored it. It actually didn't get into what would be considered the trigger range, but the HCG actually did get high enough that it worked. Even with just 500 units, she's now got enough that we've protected her embryos and maximized the chances. We got 30 eggs out of her. So we're anticipating very, very strong results from that. So use the lowest amount of HCG possible. We typically will use 1,500, but if your estradiol is higher than 10,000 or 15,000, we'll start dropping it down to 1,000 or even 500 if you're way up there in terms of estradiol.
My first FET fails.
Sorry.
I've given myself a few days to grieve, and I'll be resuming higher intensity exercise until my next one.
Okay.
Is there anything else I can do to increase the odds of success next time?
It depends on what you did before, so I don't know enough about you. So we have a really sophisticated protocol based on doing this show. We use 3 sorts of approaches. We have as natural as possible, low estrogen approach. We use lots of supplements, and then we use very close monitoring to make sure your lining is perfect. It's not too thick, it's not too thin. And we are going to start implementing Matrix technology, which is an ultrasound-based technology, to see if it helps us or not. And we're actually doing that for free, just to throw it in there and see if it works for our patients. So there are things you can do. Acupuncture can sometimes help. If weight is an issue, definitely bring the weight down. That's a hugely important factor for a lot of patients. The supplements can help quite a bit. Vitamin D levels, iron levels. If you are PCO, for example, you want to be on coenzyme Q10, NAC, inositol. So there's a lot of different holistic approaches to it to help you. Embryo transfers are not just about, here's your protocol, go do your embryo transfer. That just simply doesn't work for anybody. Or I shouldn't say that. It'll work for some people, but if you want excellence, that's not a good way of achieving it. So if you want something that's more inclusive, you really have to address everything, including the vaginal and uterine microbiome. So the bacteria that are in your uterus and your vagina, that also can have an impact. So we use the probiotics, we use antibiotics, we make sure everyone is getting a very thorough holistic approach. And we're pretty much at about 80% overall right now. So we're doing a phenomenal job.
I got a big question for you.
A big one. All right. I am post-golf, so we may need to go through it twice. Fire.
Loving these Q&As. Dr. V, here's a question for your next live stream.
Oh, my next one. Oh,
Yeah.
okay.
So like she asked it on YouTube.
Oh, for this one.
For this one.
Okay, cool.
Okay.
All right, I'm good.
When metrics for determining a diagnosis of DOR is discordance, what matters more? Day 3 FSH, AMH, prolactin, or AFC? For example, I have a high FSH between 10 and 12, but a good AMH, 13.5 picomoles per liter, and follicle count between 15 to 18 every month. Do I really have DOR, or could stress or something else be causing a high FSH? I just turned 38, but I've gotten pregnant easily as recently as 36.
Okay, that's a great question. Thank you for asking that. So first of all, none of the things you mentioned qualify you for DOR. So a high FSH is actually over 12 by almost every standard, and some would even say 15. So you're not even close if you're 9 to, what was it, 9 to 11, 9 to 10 or 8 to 10?
The FSH?
Yeah.
10 to 12.
10 to 12. So you're still not over 12. So you're not in that range. And like I said, some will say over 15. So that's not a big concern. Your antral follicle count is really high. So as long as they're doing it accurately, that's probably much more predictive. And your AMH is not high, but it's certainly not low and would be considered decent, certainly at 38. So do you have DOR? No. The only way someone could say potentially that you have DOR is if you do a stim and you respond poorly. Keep in mind there are many different definitions of diminished ovarian reserve or poor responder, and one of them is your response to a cycle, a stim cycle. So unless you stimmed poorly, nothing you are telling me makes me think that you have diminished ovarian reserve. So I would be very comfortable reassuring you that you should have a very good outcome.
Next question, also from YouTube.
Cool.
On the same video.
We love YouTube, so thank you for watching on YouTube. Watch all our videos.
Hi, Dr. V. What are your thoughts on Receptiva DX or the Emma and Alice? Are there any other tests that can be done to check for endometriitis or inflammation?
Okay. So Receptiva is a test for endometriosis, and it's useless. So I'm not a believer in it. I don't use it for anybody. It's a waste of money and time. Emma and Alice are tests to determine if the vaginal and uterine microbiome are good or receptive for your uterus. I don't use it, but we do use Fertility, which basically offers the same thing. So it may be beneficial. I was not impressed by the data from their presentation to us, wherein they told us that they knew that what was in the vagina was not reflective of what was in the uterus. And when I asked them how to treat it when there was a problem in the uterus, they said, treat it by putting something in the vagina. And when I said, you just told me that what's in the vagina doesn't match what's in the uterus, literally the line went dead, like they couldn't answer. So I wasn't impressed enough to want to use it. However, the overall theory behind it and the evidence behind it is actually supported by a lot of studies now, very clearly showing that the complement of bacteria in the vagina and the uterus can have a very significant positive or negative impact. So we use Fertility. I don't own stock. I have nothing to do with them. I talk to their doctor all the time. In fact, we have to set up another Zoom because I couldn't understand their new pricing structure, but they do basically the same thing. I think their results are more detailed and better. So yeah, that's the answer to that part. So don't do Receptiva, waste of money. Emma and Alice, meh. And they're more expensive than doing the Fertility testing. So we use Fertility, they're cheaper.
I did 2 embryo transfers. One was fresh and the second was frozen transfer. Both of them, I guess, failed. It says failed. Then before my 3rd embryo transfer, I did ERA test and I got pregnant, but it was a chemical pregnancy. My embryo was not tested. I did another retrieval and tested my embryo, and I am pregnant now after the transfer based on the ERA tests. I guess it's a comment.
ERA has been proven to be useless. The company's own study demonstrated that it was useless. So in their intention to treat analysis, there was no benefit to doing an ERA. And there are 5 other trials of ERA which showed that it was useless. So nobody should be doing an ERA. It is not a useful thing. It would be very easy for me to tell you that because you hadn't tested, some of your embryos were abnormal, maybe 1 or 2 of them were okay, but they didn't implant just because that happens. You did another cycle, you got a genetically normal embryo and then it implanted. All you need is a normal embryo and you've got a 50-50 chance. So there is no way for you to say that that was due to the ERA test. It's much more likely that that was due to your embryo quality and just trying again. Keep in mind, there are lots of studies that have shown that the more IVF you do, the higher your chances are. So you tried one more time and it worked. And thank God it did. I'm very happy for you. But do not promote the ERA. It's useless. It's completely useless. Don't do it.
What care do you recommend after DNC?
What care do I recommend after a DNC? Don't have sex for a couple of weeks. Stay out of hot tubs. That's probably about it. There's nothing really else to do. You just don't want anything going in because your cervix is open. And if the cervix is quite open, things can get in and out, and that's bacteria. So it's the wrong time to be in an environment in which there could be bacteria or in an environment that could introduce bacteria. So avoid sex for a little bit, stay out of hot tubs, jacuzzis, swimming pools, but otherwise you're good to go.
All surrogates, gestational carers I work with all do PIO, but others doing fresh or frozen ET do vaginal only. This is a very interesting statistic to see if fertility protocols are always changing. It's great to see true studies, so thank you.
Oh, you're welcome. Yeah, you know what? We have, for a long time now, used both, and it works. And we monitor the progesterone levels, we look at the compaction of the endometrium, we monitor the quality of the endometrium. Like, we really go out of our way for all of our patients to make sure everything is flawless, and that's why I think we're doing so well. That and the fact that my embryologist is like the best. She's so good. I love her to death. You know, we have loads of patients where they only give us 3 eggs. We give them back 3 blastocysts. They give us 20 eggs. We give them 20 blastocysts. She gets 100% blastocyst formation every time. My previous embryologist thought he was the best in the world, and he never once had 100% blastocyst formation. So, you know, we have very, very uniquely good results. We just started a time-lapse incubator, which I know I presented on the show as not being beneficial, but it was good for her workflow, so she made me get it for her. And we'll see, maybe it does improve the embryo quality. There were some studies that came out after I presented on the show saying time-lapse is not helpful, saying maybe it could be. So maybe we'll revisit that sometime in the near future, but I'm keen to see what our embryos and our blastocyst formation is like after we've had the time-lapse incubator working for a little while. So we'll check it out.
Thank you for sharing this. I'm currently using daily vaginal progesterone and PIO every 3 days, and I feel so good about this protocol now.
Awesome. Yeah, should be good. Make sure your levels are getting checked as well, because they are important. But that's a very reasonable protocol to use, and obviously resulting in great success. So yeah, you should feel good about what you're doing. You're doing the right thing. And I know for all of you women out there that as a guy, I can't in any shape, way, or form imagine how horrible it is to inject your buttock with progesterone and oil. I know it's horrible. So you're all warriors, and I totally have nothing but respect for you. So thank you for making that huge sacrifice. It cannot be easy, and I know for a lot of women, they react to it, and it's very uncomfortable. So thank you for everything you guys are doing. You do set the standard for all of us. Lots of hearts to all of you. Yeah.
I've been on vaginal progesterone before and always had a very high prog.
Yeah.
We'll be doing vaginal plus PIO for the upcoming transfer. Is it possible to have too high product.
Yeah, it is. So you can overdo it. Sometimes we have to titrate down the progesterone in oil dose because some women just absorb it a lot, or absorb it much more than other women do. So if your level is too high, you need to cut back. And if you're cutting back, cut down the PIO, because that's the one that has the impact on your bloodstream. It's not the vaginal.
Was on injections and pessaries until the 13 weeks. Now told to just pessaries until 26 weeks. Is that okay?
Yeah, that's what we do. So we keep injectable till 12 weeks. 13 is probably a little overkill. Most people would say 12 is overkill, but we keep them on it till 12. Then we cut the vaginal dose in half, and we stick with that till 36 weeks.
What dose of PIO do you start patients at? What does
50.
vaginal progesterone? What does vaginal progesterone?
What about vaginal progesterone? So we use 50 milligrams of oil as our starting dose for almost everybody. And then we use, depends on which progesterone. So I do like Crinone. Crinone's a great product. So it's 1 twice a day. We use a lot of Prometrium. So that's 2-3 times a day. And then endometrium has actually been proven to be a very good product as well. So for those who are using endometrium, it's 1-3 times a day. So they all have their own dosing. If you're using custom compounded suppositories, most people are using 100 milligram vaginal suppository 3 times a day or twice a day. So it depends on who's making it.
What is your opinion of the Zymo chip for sperm and calcium activation on the egg to improve fertilization?
Yeah, there's no data yet that shows that Zymo improves fertilization. The problem with Zymo for IVF is that if you have really weak sperm, you basically get nothing out of the other side of the Zymo. And if you have really good sperm, then you don't need the Zymo. So it's great for insemination, and we use it quite a bit there, but it's not great for doing IVF necessarily. It could be helpful if your only problem is high sperm DNA fragmentation, but you can overcome that by just ejaculating 3 hours apart because the second sample has less DNA frag. So we don't use a lot of Zymo for our IVF cases. I am keen to try it a little bit more, but my embryologist, my lab director, does not want to do it too much yet. In terms of calcium for activation, that has been proven to be beneficial. So there are several studies which show that that can help things. Having said that, we have not had any cases where we have less than 80 to 90% fertilization. And in almost all of our cases, we're getting 100%. Now we do use ICSI, but it's extremely rare for us to get less than like 80, 90% fertilization. So we don't need it. But if you are having trouble, calcium activation can help for sure.
How do you decide whether to transfer on day 3 or day 5? For example, if there are 12 eggs retrieved, 8 mature, 6 fertilized, 4 developed to day 3, would you transfer or wait till day 5, age 37?
If it was your first cycle and you can afford to do it more than once, I would go to day 5. Because if your embryos don't make it to day 5, you need to know that that's an egg quality problem. And that's actually a reasonable number you got. If you had 8 that were mature and fertilized, and you ended up with 4 that were, they ended up with 4 on day 3.
4 developed to day 3.
Out of 8 that fertilized.
8 mature, 6 fertilized.
Out of 6 that fertilized. Those aren't great results. Sorry. So I would grow them out to day 5, because if your embryos don't make it to day 5, the likelihood they're going to make it inside you is low. Having said that, if you can't afford to do it more than once, and you're getting that kind of attrition rate where you had a reasonable number of retrieved eggs, only 8 were mature, only 6 fertilized, only 4 are still alive on day 3, you might want to try for a day 3 embryo transfer. Not necessarily fresh, because I am a big believer in frozen embryo transfers, but you might want to freeze them on day 3 and transfer later on day 3. That's not an unreasonable consideration. If you can afford to do more than one, I would go for day 5. If you cannot afford to do more than one, I would probably do it on day 3. You got to individualize. I always say, we're making babies, not cookies, right? So cookie cutter medicine does not work in infertility. A lot of places do that, but it doesn't always work. Someone just asked, what progesterone blood level do you consider too high? Over 40 in the nanogram per mil is pretty high, and over 100 for the picomole per liter.
Good night, Dr. Victory. What protocol will you use on a patient who has elevated immune Th1, Th2, 55.2, and 44.1 levels? Thank you. For FET, sorry.
Yeah, so those are patients that are good for either the intralipids, subcutaneous IG or IVIG will work. I don't think lit therapy works for that, but it might. Steroids will work as well. So there's a variety of different approaches to it. So we typically will try some of those, or in fact, many of those all at the same time.
Is 0.25 estradiol twice a week too much for FET? My doctor kept me on even after transfer for 2 weeks.
0.25, is there a unit?
No unit.
If you're talking milligrams, that's almost nothing. If it's a patch, that's a 25 microgram patch. No, that's probably pretty low. So that's minimal. I'd be okay with that. And we keep our patients on their estrogen dose if we start them on it for the 12 weeks. I don't mess with things once I've started them on it. But we try and minimize it going in so we don't have to keep them on estrogen at all.
What to do for partial DQ alpha match and low LAD levels?
You asked that one before.
Oh, they must be playing around there.
Yeah. So we talked about the DQ alpha. DQ alpha is very difficult to manage. You can't always manage it. So that's a problem. Low LAD is something you treat with lit therapy.
Can you do a fresh transfer when doing mid-luteal IVF?
1,000,000,000% no. So if you're doing luteal phase stim, you've already had your lining exposed to progesterone. It's impossible to do a luteal phase or a fresh transfer because your lining's already been way overexposed to progesterone from your release of your egg before or your previous stim and retrieval. So you absolutely cannot do it. You're literally putting your embryo into a uterus that's got birth control, so that won't work at all.
How long do you recommend waiting to have another FET after a blighted ovum?
You can go ahead after you've had a period. So if you had like a DNC, you'll bleed for a couple of weeks. Usually around 6 weeks, you'll have your period. You can do it again right after that. And some people would argue that the scratching of the inside of the uterus from the DNC will help. I have seen that happen. The concern is it can also introduce infection, which can decrease your chances. So I don't know, but there's no need to wait. You can go ahead anytime you want.
Cycle day 21. Blood work and ultrasounds show no LH surge or ovulation and low estradiol.
Sure.
I had an egg retrieval last month. Can this cause delayed ovulation? My cycles are typically very regular.
An egg retrieval can mess up everything. I guess the other question would be I'd check and make sure you're not pregnant, but there is a possibility that doing an egg retrieval could throw things off for you for sure. So can stress, various medications you may have been on and so on. So I wouldn't worry about that for just 1 month. Wait for your next month and see what happens.
Oh, good question. Well, I don't show up. Yeah. Do you have any tips on PIO shots? I have been doing the shots for 7 weeks. I use a heating pad on my muscle before and after shots, but they are really starting to get hard to handle. My muscles just seem to be too sore. I'm only on daily injections.
So you can go to once every 3. It's being shown to be non-inferior, which means it's not better, but it's certainly not worse. So that's safe. You can try that, and that should reduce the pain. and then supplement in the vaginal if you're worried about it. Arguably, after 6 weeks, your embryo is rock solid. So you probably, and I don't want to take responsibility for this, so please don't blame me if you do this and things don't work out, but you could probably go off. People actually think I'm crazy for making my patients do it till 12 weeks. I just believe the biology is there to justify that, because it takes about that long for the placenta to really take over progesterone production. But you could, in theory, start to wean down. So that's a reasonable approach as well. Heating the buttock and the area, or a warm pad before and after, is really helpful. Those sorts of things work. The other thing is to make sure it's actually going in the muscle, because a lot of people are only getting it into their fat, and that kills. So that can help. And then the other thing some people notice is that the different type of oil, because there's like peanut oil and sesame oil and all sorts of different oils, can actually make a difference as well. So you may want to explore the benefits of using one versus the other.
Can you explain the difference of doing a letrozole medicated IUI versus Menopur?
So letrozole is a pill. Typically, you'll only make 1 egg, maybe 2. And it has roughly, if you're PCO, it's got roughly an 8% to 10% chance per month. Maybe a little bit higher in some cases, up to like 10 or 15%. So it's a reasonable approach to things. If you're doing Menopur, you're going to produce potentially way more eggs, hopefully not too many if you're just aiming for IUI, but you could over respond. And your success rates typically are more in the like 15 to 20% range, sometimes even higher, but with a very significant increase in your risk of having more than one baby. So multiples are much, much more common with doing shots than they are with doing pills. With letrozole, you have somewhere between a 5 to 8% chance of twins, less than a 1% chance of triplets. With Menopur and shots, you can have anywhere from a 20 to 40% chance of multiples, of which a substantial percentage can be high order multiples.
How do you get your follicles to grow more consistently during medicated IUI? I had 17 and 23 millimeters at trigger this cycle and 14 millimeter endometrium thickness.
The only way to really line them up is to take the birth control pill ahead of time or do estrogen priming. There isn't really another way to make them grow together unless you dose your medication differently, like higher doses, lower doses, because your eggs grow based on how many FSH receptors they have, and you're giving them FSH. So if you kind of soak them, they grow more together. But if you don't soak them, the one that has more FSH receptors will take up more of the FSH. So, if you give a really high dose, you can get more recruitment and more linear recruitment, but that doesn't always work. And then you're risking getting, 10 eggs. So you can't do an IUI with that all the time. Couple more, because I'm fading.
Yeah. Couple more, no problem.
Okay.
I heard that several IVF cycles cause borderline ovarian tumors. Do you believe this to be true? If it's true, what causes the borderline ovarian tumor? Is it medication, the reason fertility patients needed IVF, or the puncturing of the ovary? Yeah.
That's a good question. We reviewed a study on the show a couple months ago, right? Which showed that there is a slight increase in your risk of borderline tumor formation. So that is a possibility. And that's not a good thing, because borderline tumors can act like a cancer. And some of them can actually be aggressive. So you don't want borderline tumors. So you never want to do more IVF than you have to. When I talk to my patients about doing IVF, some people say, oh, we're just going to keep trying. And I tell them, like, that's not a good idea. Sticking, medications and needles and anesthesia and all this stuff into you over and over again is not necessarily always safe. So what causes it? We don't know. It's undoubtedly got some component of stimulation in there, but it could just be recurrent injury to the ovary with a needle. Like, keep in mind, guys, a needle's not supposed to go into your ovary every month, right? It's supposed to rupture from the inside out, not from the outside in. So this is undoubtedly a harmful process to some extent, especially if you're overdoing it. So you need to be cautious. Like, I don't like doing IVF over and over again. There are loads of places I know of that will just keep bringing patients back. Oh, you want to try again? Great. Your money's green. Let's do it. We don't work that way here. If I don't think it's going to work for you, I will literally try and talk you out of spending your money on it, because I don't want to take somebody's money for doing something useless. I like to sleep at night with a clear conscience. So, yeah. That's if I get to sleep at night.
Maybe today.
Maybe tonight. I'm on call again tomorrow, though, so I'm going to get killed.
What would you consider the age cutoff to be for an egg donor? My sister's 38, had 2 successful pregnancies, currently doing dual stim with you, but just thinking ahead in case we aren't successful.
Oh, so you want to be the egg donor for your sister. Okay, so with sisters, we don't have a cutoff for age, although if you're over 35, I'm going to have a long talk with everybody about the risks and benefits. But with a sister, I would happily accept up to 35, especially if you've got strong ovaries. For any donor, the ideal is 21 to 28. We do make exceptions for some women who are very good donors, have very strong ovaries, a high AMH, they're really healthy, they fit all the criteria. If they're like 31, 32, as high as 33. Beyond that, the risk of having genetically abnormal eggs begins to increase. And so your success rate goes down because you're ending up with less normal embryos. And then you don't really want to do PGT testing because that's not beneficial. But now the patient has to pay over and over again to maybe this one's normal, maybe that one isn't. So it kind of starts to get financially onerous for people. So 21 to 28 is the best. If it's a sibling, I'm willing to totally break the rules because obviously there's a genetic, tie there that supersedes just basic stuff like age. But if you're the 38-year-old and your sister is older or younger or whatever the case is, 38, it would not be advisable to use you as an egg donor. Would we do it? Yes. Have I done it? Yes. Is it successful? It's tough to get people pregnant the older they get. So yes, it's successful, but not at the same rate as doing an egg donor. Our egg donor success rate is no one fails. Let's just put it that way. So our egg donor success rate is incredible. So you're not going to get that if you're using someone that's 38.
Why would Northwestern go through with a egg retrieval with an estradiol of 415? I did get 6 eggs, 2 blasts, all generally not normal. Wasn't that too low to continue? 42.
Wow. Okay, so Northwestern, I only know Eve Feinberg, who I think the world of. I actually think she's one of the smartest people I've ever met. And Eve, you're probably not watching, but if you ever do, I love you. You're amazing. Why would they go through with it with the estradiol of 415? It depends on which units you're talking about, but if it's the American units of 415, that's low, but not terribly low. But keep in mind, they're aiming to get whatever they can get at your age, because age is a significant factor. And they are looking to try and get as many eggs as possible. This is not about Eve at all. I have nothing but respect for her. But in general, in the US, IVF is much more of a business. To be honest with you, it is in Canada now too. But I never want us to be that place. So when we get patients that aren't doing well, we cancel. Or at least I try and talk to them about it and say, look, you're not doing well. What would you like to do? And if I tell the patient, look, I'm only anticipating you're going to get 1 or 2. This is not a good cycle. But they want to go ahead. Well, that's their prerogative. I'm not going to tell them they can't, especially if they've already invested time and money into the meds and they can't get that back. But if you have good insurance coverage, all we've done is a little bit of monitoring, we usually just write it off and let you try again and tweak something to do better. I don't want people going through it unless they're going to succeed. So I can't answer for why they did that at Northwestern. I can tell you that Eve is a very, very bright woman with exceptionally high success rates. And she runs a very, very tight ship. So I have nothing but respect for her. And if she's your doctor, I would ask her. If she isn't your doctor and you're at Northwestern, she should be, because she's amazing. So ask her about it and see what happened and get some answers for yourself for sure.
906. What do you want to do?
How many more have you got?
That's the question we shouldn't ask.
No. We could be here all night. Let's do one or two more and then I got to go.
Okay. Here we go.
Yeah.
First IVF,
Okay.
6 eggs, no genetically normal eggs, estradiol 415, protocol, letrozole, gonal.
Oh, that was the same lady. That's got to be the same lady.
It is not.
It's not. Oh,
It's not.
Okay. Same levels. All right.
Levels, yeah.
415.
Unless she got another alias.
Gonal and
Gonal, Menipur, Gannerlex.
Gannerelix. Yeah.
Okay. Second IVF.
Yeah.
Microlupron, gonal, Menipur, estradiol level 1882.
Yeah.
8 eggs retrieved.
Yeah.
Waiting results.
Yeah.
What other protocols can work for me? AFC shows 13 plus eggs, but 6 to 8 eggs are received. Why? My stems are slow and don't show results until day 8.
Okay, so slow stem is not good. And if you're getting a slow stem, no matter how many eggs you get, the quality will be compromised. And we've reviewed that on the show. So if you're going past day 11, 12, your quality is going to go down. So things you can do to accelerate: DHEA, testosterone priming, human growth hormone. So all of those have been shown to kind of improve the success rates. So I do think those will work. I am a fan of the microdose Lupron flare protocol. We use that a lot. The only other one you didn't try, which some people use, are trying Clomid or letrozole as part of their stim. That's reasonable as well. I don't find that it works, so I never did it. But we get a lot of success with the microdose flare approach, so I love that. The other one you might want to consider is just do duo stim. So back-to-back cycles, because you can catch the rest of the follicles you missed in the first batch. And that's a very reasonable approach for you as well. The other part of it is making sure they trigger you correctly. So make sure they are getting all of the eggs you produce. So double trigger, so a GnRH agonist, and then some HCG. And if I just talked to a couple in Slovenia over the weekend, and she had very poor ovarian reserve. She was only making 1 or 2 eggs. Every time they would retrieve them, they wouldn't get an egg. So I said, well, weren't they flushing? And she said, what? And they didn't even know what flushing was. So for us, if you have less than 10 eggs and we're doing your egg retrieval, we use a double barrel needle. So the needle has 2 chambers within it. So one allows you to suck the egg out, and then we wait while holding it totally steady in the follicle. And if the embryologist doesn't see an egg, we flush fluid back in through the other chamber in the needle. It re-expands the follicle, and then you drain it again through the other chamber, and you just keep doing that until you get the egg. With that technique, we get them all. So it's very rare that we miss any. So if you have low number of eggs, we use a double lumen needle, and we get them all that way. So, and frequently the lower the egg number, the more we have to do that for some reason. So we do a very careful job of making sure we get every egg you have. So double trigger, flushing if you need it, use, the microdose flare or duostim. Duostim's awesome. It works really well.
Last question, easy question.
Excellent.
You'll like it.
Okay. Who is Tarek?
Yeah, that's here today.
You know what we got to do? We got to put up a post with like your silhouette, but black, and then say, what do you think Tarek looks like? Yeah. Well, you should do that. Set that one up. All right.
How long after we get a referral does it take to get an appointment with the incredible Dr. Victory?
Oh, well, I'm not incredible. Although my kids say I am recently looking more like Mr. Incredible, before he gets in shape. In the red suit with the belly sticking out. So that's about the only incredible thing about me. Yeah, it depends on the urgency and what it's for. We do try to prioritize based on age and need, and as well, like if it's a cancer case and that kind of thing. But it's not too long. So I think right now we're booking into like October, November. And if it's urgent, let me know and I'll squeeze you in. So yeah, we don't make you wait too long. I have patients where they contact me today and I talk to them within a day or two. So it depends on what's going on and how badly you need our help. We need to help a lot of people. Because of this show and a lot of the other activities we have, and hopefully, I guess, the nature of our team in general, we've become quite international. So we've got people coming from all over the world to us now. And so we need to help everybody. So I have to prioritize. And so we try and help those who are either like, going to lose their ovarian function, or those who are, in dire need for some reason or other. Again, like cancer cases as the highest priority, and then we get to everybody else in a timely fashion, but it can take a couple of days or weeks. So we'll get to you. And if you're ever frustrated because it's too long a wait, let me know. Reach out to me, DM me, say, hey, I've been waiting too long. I've got an urgent need, and we'll triage you and figure it out. And we have other doctors working with us here now too. So I'm always overseeing everything, but I can always hook you up with one of them, and then they'll bring me the information, and that lets you kind of get in at the start. Would I cancel an FET if the progesterone level was over 50 nanograms per mil? Nanograms per mil? Yes, that's a really high progesterone level. We would cancel. We might drop your dose and wait one more day if you were scheduled for day 5, because day 5 embryos can be transferred after 5 or 6 days of progesterone, but we wouldn't continue it beyond that. And with that, I need to bid you all farewell because I need to go home and collapse. So love you guys. Thank you for watching. Thank you for following us on Instagram. We are starting to grow there, and that's nice to see. Make sure you tell your friends about us. We always want to help out more people, and let us know what you want us to talk about. If there's a specific topic, we can review that. We had a bunch of DQ alpha questions tonight, eh? Maybe we'll do DQ alpha. If you guys like the idea of DQ alpha mismatch, I'm certainly happy to do that. It's kind of niche. So I'm not sure how many people want us to talk about that, but we can definitely look at it. If you do have immune problems, we did do an entire video on a review article of what treatments actually had proof for their use in reproductive immunology, and that was probably a year and a bit ago. It's on the YouTube channel. Maybe when Tarek puts up this video, he can put up the link for that one as well. And it was a good review. So they went line by line through each one and showed which ones have proof and which didn't. And then I explained it all to you guys. So take a look at that. It's on our YouTube channel. Go ahead and find it. Have a great night, guys. We'll see you back next week on Fertility Fact or Fiction.